So challenging the reality of rehabilitation is not what you think it is, in my talk anyway. So what is the reality when we're talking about XR and rehabilitation? From an implementation standpoint, there is a lot of friction in getting XR in rehabilitation. Other areas, again, a biased view, and after talking to some people here in whole health and education and some other areas that I think are low friction do have more friction than I thought. And it's because, again, organically we don't interact at that level and how we're going to use that. So the great thing is we have an ability to work through those things. And the VA is very good at it. With heads and headsets, we've got a lot of progress in reducing some of that friction. Heads and headsets is necessary and will continue to always be necessary. It's always a huge focal point in getting it. But what do we do after heads and headsets, right? So I'm going to show you, it's a really quick video. In Detroit, we're part of the Pain Pilot program, and we failed, and I take full responsibility for that. This is what it looks like when we tried to implement.
Jump into those birds.
That is not part of the pain program. That is actually a former PhD student of mine, highly intelligent person. First VR experience, and what did? They put him on Ritchie's Plank experience. Bad idea. In his high cognitive ability, he thought, this is a safe space for me to feel like what it's going to be, to free fall. Cognition is always overpowered by perception until you're exposed to it over a period of time and you can control that. But he really thought, oh, this is a safe space. I'm not going to die. But he was up there, didn't wait for all the instructions of, carefully step off if you're comfortable. He's like, free fall. And then physics came into play and his legs collapsed. His reality was no longer the same, right? That's sometimes how implementation goes. You get excited, we've got heads and headsets, we go back, and that's where we have some troubles. So, first thing, this is where I'm either going to lose my job or maybe people will, I don't know. But we all contribute, everybody in this room, to making it work or not work for implementing XR. Therapists, researchers, healthcare organizations, including the VA itself, manufacturers, everything. We all play a part in it. On the left is just a little graphic. XR, in a lot of times in rehab, is inaccessible, and we'll talk about what I mean by that just in a more broad sense. It's misunderstood, it's misinformed, it's misguided, and misused. So as I talk through this, think about your role. Not only how you help implement it, but what are some of the barriers that we each right? The failure in Detroit for the pain pilot is because of my expectations and my experience at VR. I got to Detroit, and nobody was interested or knew anything about VR. I saw that. I was here like a month. I was like, this is great. This is Candyland, right? I'm like, yeah, I'm in. And it got here, and what my expectation and my experience of VR didn't match. And I realized right away, I wasn't the one who should be leading this here. And it was hard to find somebody. Everybody's in so many silos reaching out, but I finally found some psychologists who did it. But they're only doing it a couple of times a day, not enough for it to be meaningful for the pilot. So there are people who are able to use it, and we're going to be returning it because that's the right thing to do, and it needs to be somewhere it's going to be better. And so it's a learning process from us on our own. So when we're talking about accessibility, we always think about physical accessibility, cognitive accessibility, and things like that, and that's true. But we also have to think about, and I'm going to just go through these, not all of them, but just highlight a couple of them. Because what I really want to happen out of this is I'm not going to provide you any solutions, I'm only going to make you have questions. Because I would really like to see dialogue about all these things. So in addition to what we typically think about accessibility, I want to also think about access. From accessibility to the form factor, many people have already talked about, we're all aware of those. Input controls, if someone has limb loss, do you have the ability to use hand tracking and get rid of hand tracking and use controls, and are controls appropriate? How do we do that accessibility? But the other thing is, from an implementation standpoint, is research access is one. What do I mean by research access? No offense, but the VA article is behind a paywall. I tried. Now, I think if I'm on my VA laptop, I think I can get access to it. It's a great article. I actually have read it. but it has limited access for anybody outside the VA to go, oh, hey, unless I pay for it, right? Researchers, you have to pay a lot of money to get into some of these, unless you go open access, and then unless the person who's reviewing that knows it's open access and knows how to tell if it's a good research study or not, it limits the understanding of what that means, right? XR platform business models, they have to make money. We need them to provide things in an affordable way, and then we demand more options and things like that, but we have to understand what their needs are as well in implementation. They can't do it for free, and they can't do it always for cheap. In the future, the models will change, and it'll be there, but it is a barrier to access. Misunderstanding. The biggest one is ambiguity in terminology from the XR community itself. I started out on Milgram's reality continuum. Mixed reality has like 8 different ways it's been defined since then or more. People mix up AR, XR, in the research, in the clinic, between platform providers. And what people expect from certain things based on what their understanding is of XR affects their implementation ability. And veterans don't know the difference either. They come in and when you try to do something with XR and they're like, that's not what I was expecting, right? Misinformed, if we're not really misunderstanding some of the things in XR, then we teach each other incorrectly. I think at the clinician level, it's still out there. Clinicians don't have a full grasp of it. We aren't doing a good job educating them and training them and teaching them. Healthcare organizations, if we are misinformed or we don't understand it, we're making the recommendations to purchase, and it's the wrong thing, and then we go back and say, hey, remember we said this was going to work? It's not right for us. We'd like to do something different. What is your director going to say? Look, you told us it was right. We spent this money. Not only affects you, but it could affect somebody else who's down in another department who wants to try VR. And their director says, you know, we tried that there. That didn't work. We're not going to spend that money. We're kind of hamstringing everybody else. We then take that information and we misguide others. Our clinical guidelines, the American Stroke Association Stroke Rehab Guidelines says, yeah, you can use VR. It's okay. But if you actually read the research they're referencing, it's the Wii and the PS3 iToy. Those are non-immersive VR experiences. And people equate that to immersive VR. And the strategies I use between those technologies and the interventions I use are very, very different, and their behaviors are different, right? The way that they interact with it. And so that can lead you to go, oh, this isn't the right technology, and you abandon it. It collects dust. And then we misuse it. Excuse me. So when I just talked about the clinical guidelines. I'll just skip right over that part, but get to the one part for me that's really important. For vendors, for payers, and especially the VA who wants us to code correctly, we have to make sure that those VR experiences allow the clinician to use skillable interventions. The biggest mistake every clinician makes, myself included when I first started out, is you watch the screen, you watch the tablet, and you're giving feedback based on that, but your eyes aren't where they're supposed to be, on the patient, on the veteran, doing your interventions. VR is not just a tool, it's a virtual context of how you're applying your strategies. So those are some of the things that we do that create barriers, or we can use them to facilitate implementation. This slide is just for you for information, because A, I don't want to read through it, and B, it would be really boring, but you can kind of refer to it later. But these are some of the implementation science terminologies. But what I want to do is have you think about those from your own perspective as how your interaction with the accessibility, understanding, and use of XR plays a part in each of these. So the point I'm going to start out with is the heads and headsets. These are some of the implementation things, just some of them, that heads and headsets accomplishes. Acceptability. When you get that you're in that headset, you're like, oh, I get it. I see how I could possibly use this. It's appropriate. Yeah, I think it would be right for our therapy patients if we kind of applied it that way. Is it feasible? Yeah, if we can get funding for it, we've got the staff, if we can do the training. The adaptability. 3,500 headsets and penetration, that's high, but it's very high superficial level. What happens after heads and headsets is vital. As soon as it gets to the local site, you have to start all over again, because where it typically breaks down is the fidelity of what you've selected. So if you've selected something and you try it out and it doesn't quite work the way you thought it did, it's doing what it's supposed to. It's doing what they told you it was going to do, but boy, now that I've got it in my hands, I'm using it, it's different from my experiencing it. And you can't just ship it back. My time is up, but I have just a couple more minutes. So, but then all of a sudden we can't sustain it, because if it's not appropriate, you're not going to use it. And then there's all those consequences that come after that. So how do we kind of get around some of that? We want to avoid face planting, using it the wrong way, changing our aspects. But the key is looking at the factors of implementation, looking at, what are the things that we do that cause us to misuse XR, and how do we overcome them? Because here's the problem. Each of us contribute to it, and then we try to solve our problems, but we don't look at it from how other people are trying to solve their, and you've heard it countless times. How do we work together to do that? How do vendors come together with therapists, with leadership at a local facility, right? Where do we need to be getting people together to work at that local level to make sure that what we're getting is the right thing? Should we find a way to do trials so that to make sure that it's the right thing before people purchase? But how much of a burden does that put on vendors? How much does that increase their cost? And are you willing to pay a higher price to make sure that they're able to do that for us? We have to find a way to be willing it. Current budget situations make that hard. These are only just some questions. They're kind of questions to get started. And the whole point of this is to think about, what do we do after heads and headsets to keep things from failing? We have 3,500 headsets out there, but I guarantee right now, I've got 5 that we're using them right, and it's our fault. And we need to find a better way that after heads and headsets happens, to make sure that the technology we're getting in there gets to the right people, the right place, at the right time, so that we're using it the right way. Because the last thing you want to do is make it harder for somebody else to be able to experience that. So, apologize for going over. Thank you for your patience. Thank you again, Evan and Gary. Appreciate it.